What I'm going to talk about today is a meta-analysis of trials of dose intensification of chemotherapy. And I'm presenting this on behalf of the Early Breast Cancer Trialist Collaborative Group, and which is a collaboration between just about all of the breast cancer trialists worldwide who share individual patient data in meta-analysis in order to get more reliable findings. So I'm talking about so the background to this research is that we know from a lot of previous research that giving chemotherapy with an anthracycline and a taxane, two commonly used agents, can reduce the chance of a woman dying of breast cancer by about a third. And we're still trying to find ways of improving how we deliver this chemotherapy. Typically, it might be given for about 8 courses every 3 weeks. And we've tried to look at trials that have increased the dose intensification. And the rationale for this is that if you look at models, computer models of how cancer cells get knocked back by chemotherapy, then regrow again, it seems that if you increase dose intensity, you might be more likely to eradicate all cancer cells. And what is dose intensification? Well, it's very simply the amount of drug you give in a given time. So usually chemotherapy doses are given in milligrams per meter squared. If you can cram more dose into time, then that is intensifying treatment. And there are 3 ways that you can intensify drug treatment. And one of those is just simply to increase the dose of the drugs. But the problem with that is that you have limited by toxicity, and it also seems that the relationship is not linear. So if you have twice the drug, you don't get twice the benefit. You get a limitation. So a cleaner way of intensifying the dose is simply just to give the drugs in a shorter interval. So instead of giving them every 3 weeks, you give them every 2 weeks. And that's been difficult to do because it takes women a while to recover from the chemotherapy before they can start the next course. But by giving drugs that stimulate the immune system, make the white cells grow back faster, you have been able to, for the last 20 years, give drugs every 2 weeks instead of every 3 weeks. But another way you can increase dose intensity is instead of giving the drugs, the taxane and the anthracycline at the same time, you give them sequentially. First you give the anthracycline, then you give the taxane. And this is another way of increasing the dose intensity. And I say the models of the basis for this is work that Larry Norton published nearly, quite a while back now, isn't it? So 20 years ago. And the idea is if you have the lower dose, if you have a slightly lower dose therapy, then you knock the cells back a little bit every time you give a cycle of chemotherapy, but then they grow back. And if you increase the dose, you knock them back a little bit more, but they grow back faster. And especially when you get a small amount of tumour, they start dividing very fast. And so the idea of the dose dense, giving the stuff faster as you knock the drugs back, and before they can grow back, then you start the next course. And there have been lots and lots of theories like this about how you could improve chemotherapy. And they're not only a theory unless you actually test them. And so the whole series of trials set out to test this hypothesis that intensifying dose chemotherapy, the intensity of chemotherapy would improve outcome. And we looked at all of these trials, there's 25 of them altogether, and we classified them into different ways of doing it. There's what we're calling dose dense, which is giving it the treatment every 2 weeks instead of every 3 weeks. And the cleanest tests of the hypothesis were the 7 trials with 10,000 women that gave exactly the same chemotherapy, the same drugs, the same doses, but just gave it every 2 weeks instead of every 3 weeks. So that's the cleanest test of the hypothesis. But there were another 5,000 women in trials where the drugs, chemotherapy, were a little different between the 2 groups. And then we looked at the sequential versus concurrent, giving the drugs one after the other instead of giving them together. And there were 5 trials, 10,000 women or so, that had exactly the same drugs, but they gave them sequentially rather than concurrently. And again, 1 trial with slight differences between the drugs. And then again, there was also trials that combined the 2 approaches. So they gave the drug sequentially and they gave it 2 weekly, and then compared this with giving it concurrently, 3 weekly, the standard treatment. And so this is getting the benefits of both approaches. And the methods are pretty simple. We just asked people to provide the data. There were 25 trials that we obtained data for, and there were 31 trials we identified that had tested these approaches. So we got 94% of all women in these trials, and we looked mainly at recurrence and dying from breast cancer as our primary outcomes. And so these are the results of the first comparison, the clean comparison of just giving the drugs 2 weekly instead of 3 weekly, exactly the same drugs. The only difference was giving them 2 weekly. And as you can see, for looking at any recurrence, 10,000 women, this is the rate ratio was 0.83. That means that there was 17% fewer recurrences with the dose-dense approach than with the standard treatment. So it's 24% had a recurrence by 10 years with the dose-dense. Standard was 28.3. So this is a gain of about 4% in risk of recurrence. And for breast cancer mortality, the reduction was almost 15%. The rate ratio is 0.86. This is highly significant reduction in breast cancer mortality. And the difference was dose-dense, 16.8% had died by 10 years, 19.6% with the standard treatment. And this is, I say, is a reduction of about 15% in breast cancer mortality. And it may seem a pretty marginal difference, but when you think that we've already made a lot of improvements with chemotherapy, you can get about a third reduction in mortality with standard chemotherapy. If you can then give it a dose dense, then that 1/3 reduction becomes almost a half reduction in breast cancer mortality. So though it's just another step-by-step increase, these increments have made a really big difference to breast cancer survival. It's just identifying little ways of improving what we're doing already. And then we looked at the sequential trials as well. There's the 3 weekly sequential treatment versus 3 weekly concurrent treatment. And again, we saw a very similar reduction, about 15% in recurrence and a bit less on breast cancer mortality. The rate ratio was 0.89. That's just about a 10% reduction in breast cancer mortality. But the dose intensity that you achieve with the sequential is a bit less than you achieve with the 2 weekly versus 3 weekly. And this fits in slightly less benefit. But this is again significant for breast cancer mortality and quite highly significant for recurrence. So it's not really plausible. This is a chance finding. Clearly the sequential is better than the concurrent chemotherapy. And then we also looked at the trials that combined the two approaches. These gave drugs sequentially and they gave them 2 weekly versus giving them concurrently and every 3 weeks. And we found a little bit bigger difference in these, as you might expect, by achieving a higher dose intensification. This is about twice the dose intensity in these trials compared to the standard treatment. And we found an 18% reduction, a rate ratio of 0.82 for any recurrence, and all the same for breast cancer mortality, so almost 20% reduction. And then the statistical significance is very high. This is 1 in 1,000 chance. This could be a chance finding. And so these are real. So whichever way the trials achieved dose intensification, they seem to be finding benefits in fewer recurrences. And this was quite remarkable how consistent all these different approaches were in showing fewer recurrences and fewer breast cancer mortalities. So to try and look at the totality of the evidence, we then looked at a pooled analysis of all 25 dose intensification trials. And we found extremely highly significant difference in recurrence. This was a reduction of 15% in recurrence, a rate ratio of 0.85, and a 13% reduction in breast cancer mortality, very highly significant difference. And the absolute difference was, well, it's 3.6% difference in recurrence, 2.76 for breast cancer mortality. But this was across all trials. Some must be better than others. And so this is the average benefit. So if you took the optimal way of dose intensification, you would get a little bit more than what we saw there. And we also looked at the benefit across a wide range of different types of tumour, types of age, women and so on. And we found similar proportion reductions, in particular for estrogen receptor negative and for estrogen receptor positive tumours. So the conclusion is that shortening the interval between cycles and sequential administration of anthracycline and taxane chemotherapy reduces recurrence and death from breast cancer. And this is statistically completely definite. It's not just a chance finding that somebody else might fail to replicate. And the reductions are about 15%, and they were similar in ER positive and ER negative disease. And nearly all women in these studies who are ER positive would have received hormonal treatment. So these benefits are in addition to hormonal treatment, which has quite marked benefits as well. And we also looked at safety. People have been concerned about safety, and we found no increase in deaths from non-breast cancer causes. We looked at the first year when deaths from chemotherapy might occur, and we found, if anything, there were fewer deaths from non-breast cancer causes in the dose-intense treatment. So, acknowledge the funding body for this was mainly the Cancer Research UK, the Medical Research Council, but we get absolutely no funding whatsoever from any commercial interest. So, thank you. I'll stop there.